The topic today is medication safety in the elderly, 60 and better. The objectives of this presentation include highlighting the importance of medication safety in the elderly, discussing why medication safety is a concern, reviewing the etiology, discussing strategies to prevent medication errors, and discussing the role of providers in preventing adverse drug events. Increase in the elderly population will be greatest when baby boomers reach 65 years of age. By the year 2020, 20% of the population will be 65 or older. This increase can be attributed to both declining mortality rates and overall health. The fastest growing segment of Americans is the 85 years and older group. In 2002, the leading cause of death in the 65 and older age group was heart disease, followed closely by cancer. Currently, medication errors are in the top 5 causes of death. Prescription drug use in the elderly varies depending upon the number of medications taken per week. 4.2 million people take at least 10 medications every week. As of 2005, 30% of this country's health care is spent on hospital stays for the elderly. Although only 13% of the population is 65 or older, they account for more than 34% of prescription drugs. It is estimated that $25 to $27 billion is spent annually. Non-prescription drugs often account for undocumented polypharmacy issues. For examples, surveys have shown that the elderly take 2 to 4 over-the-counter meds per day, including laxatives which may not even be necessary. NSAIDs, sedatives, H2 blockers, and herbal supplements are among drugs used without a prescription. All may cause major side effects in addition to having potential drug interactions with prescription drugs. Both herbal and supplements are largely unregulated by the FDA. No efficacy or manufacturing standards are required, but they can only make health claims as opposed to specific treatment, preventative, or curative claims. Healthcare professionals should question and monitor this population regarding use of herbals and supplements. Any symptom in an elderly patient should be considered a drug side effect until proven otherwise. The economic impact of medication-related problems in persons over the age of 65 now rivals that of Alzheimer's disease, cancer, cardiovascular disease, and diabetes. Medication-related problems are estimated to be one of the top 5 causes of death in that age group and a major cause of confusion, depression, falls, disability, and loss of independence. Consultant and senior care pharmacists are committed to caring for the well-being of each individual, taking into account the complex interrelationships between disease states, nutrition, medications, and other variables. They are essential players in the healthcare team and influential decision makers in all aspects of drug therapy. Consultant and senior care pharmacists counsel patients, provide information and recommendations to prescribers and caregivers, review patients' drug regimens, present in-service educational programs, and oversee medication distribution services. In addition to these basic responsibilities, consultant and senior care pharmacists provide a wide range of other primary care services to the nation's seniors, including pain management counseling, pharmacokinetic dosing services, intravenous therapy, nutrition assessment and support, and durable medical equipment. As people age, changes in internal systems become more apparent. Often organ systems no longer function at full capacity, causing common deficiency in this age group. Listed are some examples. Recent studies show aging impacts the rate rather than the extent of drug absorption. Factors contributing to altered absorption are reduced gastric emptying and intestinal transit times, increased gastrointestinal pH, altered rates of gastric blood flow, and the presence of other drugs. Certain medications are affected by the alterations in absorption. An average 75-year-old's fat content is nearly double that of an average 25-year-old, while the amount of muscle tissue and intracellular water volume decrease in the older person. Since the distribution of a drug is determined by its chemical makeup, it is conceivable that lipophilic agents, for example benzodiazepines, barbiturates, and prazosin, would distribute more readily and completely into the fat content. The more polar drugs, such as digoxin, verapamil, and lithium, would have a smaller volume of distribution. In pharmacokinetic and pharmacodynamic parameters of drugs, hepatic metabolism and renal excretion are two key issues. Because the aging process alters pharmacokinetic and pharmacodynamic properties of drugs, special care must be taken to individualize drug therapy in this population. What other risk factors can you think of that may predispose elderly patients to adverse drug events? There are many factors, including polypharmacy and drug-drug interactions, when a patient is on multiple drugs from multiple doctors and perhaps using multiple pharmacies. Drug-disease interactions can occur when a patient's disease state prevents the proper absorption, distribution, metabolism, or excretion of the drug. Undertreatment is another potential problem. Of major concern is patient compliance or non-adherence to their drug regimen. When prescribing, careful attention must be paid to the risk-benefit relationship of treatment. What risk factor do you think is depicted by this cartoon? As you can see, when a patient reacts to a drug, often another drug is prescribed to counteract the effects of the first drug. This can lead to a cascade of prescriptions. Please read this slide for examples of undertreatment. Drug-drug interactions have infinite possibilities, and both pharmacists and technicians should be sure to inquire each time a prescription is filled. Here is a brief list of some common drug-drug interactions. Drug-food interactions include vitamin K and warfarin. Drugs may also have an impact on appetite. For example, digoxin may cause anorexia. Please consider these potential drug-disease interactions. Drugs such as tricyclic antidepressants, Benadryl, NSAIDs, and steroids can cause cognitive impairment. Benzodiazepines, sedatives, and hypnotics can increase the chance of falls in the elderly, as can selective serotonin reuptake inhibitors and tricyclic antidepressants. Non-adherence can be caused by multiple chronic disorders, prescribers' prescriptions and doses, changes in the daily drug regimen, cognitive or physical impairments, living alone, recent hospital discharges, inability to pay for the drugs, and the presence of side effects. Medications taken before, during, and after hospitalization can cause adverse drug events. Medication reconciliation is an important part of taking a patient's history upon admittance to the hospital. Reported adverse drug events are highly variable, but an estimated $20 billion is spent each year on inappropriate prescribing caused by hospitalization. Always consider an adverse drug event as a potential when an elderly patient is hospitalized. Adverse drug events commonly fall into cardiovascular meds, diuretics, non-opioid analgesics, hypoglycemics, and anticoagulant categories. There are many types of medication errors in the senior group, ranging from omission to improper dose, unauthorized drugs, and extra doses to wrong time of administration. Prescribing errors, drug preparation, incorrect administration, route, and form are also included, but at lower percentages. According to a 2002 report, the highest incidence of medication errors in seniors was omission errors at a 42.9% rate. There are many different types of studies ranging in design, patient, and results that can be used to evaluate adverse drug events. In order to avoid adverse drug events, a multidisciplinary team should be involved in the diagnosis and treatment of geriatric patients. A thorough medication history is needed to be safe. A patient's cognitive and physical barriers could complicate the history, as well as any over-the-counter, herbals, or supplements they may be taking. It's best to ask specific questions about these drugs during the history. High-risk patients include those that take greater than 9 meds, have physical problems such as poor eyesight and muscle coordination, and are on narrow therapeutic index drugs. Prior adverse drug events, greater than 6 comorbidities, and drug interactions are also of concern. In order for clinicians to help determine the appropriateness of medications, there are 10 basic questions to ask. Is the medication effective for the condition? Is the dosage correct? Is there an indication for the medication? Are the directions correct? Are the directions practical? Are there significant drug-drug interactions? Are there drug-disease or condition interactions? Is there a duplication with other drugs? Is there a cheaper alternative? And is the duration of therapy appropriate? The Beers criteria was based on a national expert panel and identifies inappropriate medication use in elderly patients. Ideally, a short-acting drug with inactive metabolites and low lipophilicity should be used. The Beers guideline include the type of medication, the reason it is deemed inappropriate, and an alternative suggestion. Please take a minute to review the charts. Here are some more examples, and the last set of examples. There are also guidelines regarding the disease state, the drug, and why it's of concern. A good rule of thumb when dosing geriatric patients is to start low and go slow. There are many safety measures in place in an attempt to prevent and reduce adverse drug events, including the Beers criteria, computerized flags or warnings, drug utilization reviews, the 5 Million Lives campaign, and constant monitoring by pharmacy staff. Please consider our role as healthcare providers in preventing medication errors in the elderly. Medication safety in the elderly is a common and preventable problem. It is essential to identify risk factors or potential drugs that may potentiate an adverse drug event. We all can play a key role by practicing and implementing strategies to prevent medication errors. Please take note of the following resources for senior care pharmacists. Medications are probably the single most important healthcare technology in preventing illness, disability, and death in the geriatric population. I hope you've enjoyed this presentation, and thank you for your attention.